there are obviously a lot we don't know. Pam made the point that we're still in the forest a little bit with some of this, and we'll show you in this case, which highlights a lot of these points, how we at least carved our own path out of the woods. So this is a case we did actually as a live case last week at New York Valves. This is a 70-year-old gentleman, very active. He could be 65. BMI kind of mid-range for the Southeast, 35. Maybe not Napa BMI. Known to have a bicuspid valve, mild non-obstructive coronary disease, prior AFib ablation, currently on sotalol and Xarelto. And he presents with really class 3 symptoms. Normal renal function, no chronic lung disease. He does have a history of a TIA remotely, which led to his AFib discovery. He's hypertensive and he has moderate carotid artery disease. His STS score is 1.2% and was deemed low risk for isolated SAVR in our surgical clinic, and actually our joint clinic. We see the patients together. Here's his echo. Low normal EF, valve area 0.98, Vmax about 4.1, mean gradient 41, no other very significant mitral or tricuspid disease. And then we had a CT assessment of his coronaries, which just shows mild luminal irregularities. So I'll pause here and just say, let's actually see a show of hands. Who would just stop here and send this patient to surgery? Is anyone? I think traditionally, this would be a point where, certainly in my practice, I've seen this quite a bit. Anyone have any other ideas?
New California surgeons.
Yeah.
With the highest rate of TAVR usage in young patients, by the way. I want to mention that out, just FYI.
But we don't get to send.
Yeah.
Yeah. So anything else people would like to see?
What are the TAVR measurements?
Yeah, as you saw, we had the coronaries. We did a TAVR CT, which is our practice for any aortic stenosis patient that comes to our clinic. So, we thought also the size of the ascending aorta obviously is very important in a patient with previous bicuspid aortic disease diagnosed. His did not end up being very dilated, a max of 3.8 centimeters. Things would have obviously changed had this been 4.7. The morphology of the bicuspid valve we think is also really important. And as you can see here, this one is actually a little bit unusual in that it's a right non-commissural fusion. More frequently we see right-left fusion, but it is a Sievers 1 bicuspid valve. I would say moderate amount of calcification. We also do get a quantitative calcium score on all these patients. And then here are the TAVR measurements that Marco was asking, and this is no need to go through this, but his annulus is 466, which is mid-range for a 26 millimeter balloon expandable valve. He has nice big sinuses around 34 to 36, no extreme root angulation, no other massive amount of calcification anywhere. So pretty favorable. A structural interventionalist looks at this and says this is pretty favorable anatomy probably for TAVR. Access also fantastic leg vessels for a transfemoral approach. What about now? Who's gonna just send to surgery? Who's going to consider other options? Is there anything else that you wanna know? Remember, this gentleman's 70. He might as well be 65 or let's say 64. He's very active. Yeah, at this age, he's not gonna get a mechanical valve, right? He's going to get a bioprosthetic valve either way, and it's likely not to be his last valve. So my only point is that we need to be thinking not just about this procedure, but we need to be thinking about the next procedure as well. TAV and SAV is pretty well, we do it routinely. We do multiple cases a week. TAV and TAV, we do less often. So to pick a TAVR first here, I think you probably better have a pretty good idea that's a good idea, that would be feasible to do later. So what we have tended to do in bicuspid patients, in young patients for the purposes of what we call lifetime management or lifetime planning, is get some modeling with some software this company DASI Simulations has. So we can model placing whichever valve would be our first valve from a TAVR standpoint, a balloon expandable 26 or a self-expanding 29. We can look at the risk for coronary occlusion. which in this patient happens to be very low for the index procedure, but we can also use this to see what the risk might be for a subsequent TAV in TAV, assuming we pick TAVR here, 10 years down the road or 12 years down the road. And this ratio becomes pretty helpful. It's a ratio of the distance from the valve frame to the coronary over the diameter of the ostium of that coronary. In this case, it's clearly not even close. So maybe this isn't the right image to illustrate the power of that ratio, but anything under 0.7 is high risk for coronary occlusion. This is 3.1. And you can actually see the coronary in the right-hand panel, try to peek out in the northwest corner of that image. So it's well above the valve frame, should be plenty out of the way.
And Dr. Stewart, I am going to have to, can you wrap up in like 2 minutes?
We'll keep it moving. Yeah.
I hate to, this is the worst
Absolutely.
part of being a moderator.
No risk of PVL. And then most importantly, we can do a stretch analysis that shows our risk of annular rupture, probably the most feared complication of TAVR. Anything under 1.6 is pretty low risk for any sort of annular rupture. We can see the distance, the height of the membranous septum, so plan how high we need to place the valve to hopefully avoid a pacemaker. And then we can actually now, from the lifetime management standpoint, we can actually model that second TAVR inside the first TAVR. And we can run those exact same coronary obstruction ratios, stretch ratios. In this patient, all of those numbers were very favorable. So we felt like if we did TAVR as the index procedure here, that we would have a very good option 10 years from now when that valve fails to come back and do a second TAVR. So from a lifetime management standpoint, we felt like we could responsibly, thoughtfully, go ahead and offer this patient TAVR. And so that's what we did. Here was our procedural plan. We don't need to run through, everyone knows what a TAVR looks like. I will point out that on the aortogram here, that certainly looks like a lot of rocky calcium. Had you not done DASI, you'd be a little worried, I think, in a young patient blowing up a balloon expandable valve in that annulus. And we got a fantastic result, very nice high placement. And the patient had an uneventful recovery, narrow QRS, didn't require a pacemaker, no vascular other complication. And then at his next day echo, mean gradient of 14, no PVL or central AI, and he went home that next day.
Thank you.
We'll leave it up to you to decide if you thought we did the right thing.
All right.